So in this video we shall be discussing regarding the anatomy, a few important steps of the embryological development of the pancreas and few common congenital disorders of the pancreas. So regarding the anatomy, we have, it is situated in the retroperitoneum. It is divided into head, which constitutes around the 30% of gland by mass, and body and tail, which constitutes around 70%. Now head lies within the curve of the duodenum overlying the body of L2 and second lumbar vertebrae and inferior vena cava. So if you look over here, this is a transverse section of the pancreas. Please remember regarding the uncinate process, right? So this uncinate process lies behind the superior mesenteric artery and the superior mesenteric vein, and this is one of the important landmarks during your Whipple's procedure. And then we have this posterior relation of the pancreas over here, right, which is more important over here is your inferior vena cava and the aorta, right. Now regarding behind the neck of the pancreas, you have the superior mesenteric vein joining the splenic vein to form your portal vein. Then we have some steps in the development of pancreas. So I have taken this table from your Bailey and Love. So there have been questions asked from this table, and hence it makes this table a very important table. At day 26, we have a dorsal pancreatic duct that arises from the dorsal side of the duodenum. At day 32, we have ventral bud which arises from the base of the hepatic diverticulum. At day 37, we have contact between these two buds, and fusion end by week of 6th week. Then at 6th week, we have your ventral bud producing the head and the uncinate process. Then the ducts fuse, and the ventral duct and the distal portion of the dorsal duct form the main duct, which is the duct of Versum, and the proximal dorsal ducts form the duct of Santorini, which is your accessory duct, right. So the main important week to remember is your week 6. Then at month 3, we have the acini which appears, and month 3 to 4, the islet of Langerhans appeared and become biologically active, right. So the islets of Langerhans, they appear and become biologically active during the 3rd to 4th months. Now we have this image over here, right, which shows in your image A your normal pancreatic ducts, and on the right side where it is BCD, it shows your suppression of your accessory duct, whereas in your EFG over here shows the suppression of your main accessory duct. Now the disorder that is associated over here is your pancreas divisum, right. So this is basically the failure of the fusion of your ventral and dorsal part of pancreatic duct, right. So what happens over here is that the dorsal pancreatic duct now becomes the main pancreatic duct, right. So with the dorsal duct becoming the main pancreatic duct, it drains the most part of the pancreas. So what happens over here is that since the minor papillae, right, is smaller than the large, when the large volume is going through this narrow papillae, there is going to be incomplete drainage, and this incomplete drainage is going to cause your obstructive pain and pancreatitis. Now how will you diagnose this? This is going to be diagnosed with the help of MRCP, ERCP and EUS, right. And if we need to treat this, you would need your surgical intervention. So your surgical intervention would be coming in form of your sphincteroplasty, or it could be a pancreatico-jejunostomy, or it may even involve your resection of pancreatic head, right. So these are few important points with respect to your pancreas divisum, right. So and apart from the surgical intervention, what I forgot to mention you guys is regarding your endoscopic intervention, right? So the endoscopic intervention would be in form of sphincterectomy and stenting, right? So these are few important points with respect to your pancreas divisum. Then another very important congenital anomaly that needs to be studied is with respect to your cystic fibrosis. So the mode of inheritance is your autosomal recessive. So this is a very frequently asked question with respect to your cystic fibrosis. Then you have a mutation in CFTR gene, which is situated on your chromosome 7. Then it is a disorder of exocrine gland that affects your lungs, intestine, pancreas and liver. The characteristic finding that we see is your elevated sodium and chloride concentration in the sweat, right? So please remember and look for this clinching one-liners in your question. And another important point with respect to your cystic fibrosis is that it is one of the most common cause of chronic lung disease in children in resource-rich countries, right? And the diagnostic criteria is level more than 90 millimole per liter, which confirms the diagnosis. Then we have another important topic, which is your annular pancreas. So this is the failure of complete rotation of ventral pancreatic bud. So as a result of which a rim of pancreatic tissue surrounds the second or the third part. Now if you need to answer one, then it has to be a second part of the duodenum. Now it is associated with your congenital duodenal atresia and stenosis, and your treatment would be your duodenostomy. Then regarding the ectopic pancreas, so what are the location or the sites of your ectopic pancreas? They may be presented in the submucosine parts of stomach, duodenum, small intestine, even in the mecal diverticulum, then in gallbladder, hilum of spleen, liver and your wall of alimentary tract duplication cyst. So these are some of the basics of the anatomy and the embryology with respect to the pancreas.